Today, I want to talk to you about the truth about tonsils, adenoids, and airway problems in kids. First up, what are tonsils and adenoids? Tonsils and adenoids are a part of your child's immune system. They sit in the back of the throat and behind the nose. We have this upper part where we breathe in through the nose and it arrives to the back of the nose called the nasopharynx, and through the mouth, when we go through the mouth and arrive to the back of the throat, that's called the oropharynx. And that is respectively where I put these yellow arrows pointing to up top is where the adenoid tissue is, and down below is where the tonsils live. And in order to evaluate these different tissues, there are a few different approaches. So if you go into the doctor and your pediatrician uses that popsicle stick and they have your child say, ah, they're looking in the back of their throat and evaluating the size of those tonsils likely. The adenoids can't be so easily visualized in the same way because of where they're located. And so sometimes we have to use a small camera that an ear, nose, and throat doctor will insert through the nose, and it will go to the back and get a view of what's going on back there. And additionally, though less commonly in an ear, nose, and throat setting, but more common in a dental setting, we're going to get some more information on the size of these tissues based on a X-ray that's taken. When it comes to kind of grading the severity of these tissues, I'm going to run through the Brodsky scale for looking at the tonsils. And this is going to show you that here we have grade 1 is where the tonsils are just living in the area where they belong. They're not necessarily enlarged. They're kind of confined to the anatomical space where they're supposed to be living. And then grade 2, we have where they're extending slightly beyond the area where they live. It's called the pillars, that area. And by the time we get to grade 3, we have some more enlargement such that this tissue now occupies around 50 to 75% of that airway space when we're looking in. And when that becomes even higher, we have grade 4, or sort of what's called kissing tonsils, because they're now so big that the right side and left side tonsils are basically kissing each other. They occupy around 75% to 100% of that airway space. And generally, when we see grade 3 and grade 4 as the gradation, it's much more likely to be significantly impacting breathing. But we can't use just the visual assessment alone. We have to combine this with symptoms and kind of understand more of what's also going on in the nose and the other parts of the airway space. Dentists are often some of the first ones to spot the warning signs of any problems with tonsils and adenoids being enlarged, in part because we are looking in through the mouth, and we're doing that more often around every 6 months typically than most other providers are going to be checking in this space, if there any other providers are checking this space at all. So when we see signs like crowded teeth or wear patterns from grinding teeth, we see clues that a child is mouth breathing, or even just visually looking in and noticing that tonsils are large. Again, like I said, sometimes on dental x-rays, this is something that comes up where this can be picked up. But unless someone is sort of what's considered to be an airway-focused provider, a lot of times these warning signs can otherwise be missed or overlooked. A lot of times parents are surprised when they go to see a provider and they're still being referred to an ENT, especially if that provider that they're going to is someone who's advertising some sort of more holistic care or airway-focused care. And it can feel confusing. I understand, I live in that world, and we oftentimes are looking for alternatives to surgeries, or just not jumping straight to surgery if it's not indicated. And some providers are going to be more open to trying multiple options before considering surgery. But here is the problem. At the end of the day, your child's ability to breathe well is one of the most important functions that your child has day to day. And so if they're not getting enough oxygen, especially during sleep, this can be a really big deal. This can alter brain development. It can change the way that the body and face are growing. It can leave the body to exist in a more stressed state. And a lot of times it can make these other therapeutic interventions much harder to navigate. It can just create everything to be a little bigger struggle than it needs to be. Oftentimes, because if these kiddos are forced to be breathing through their mouth, any of these other interventions or therapies that are going to be requiring people and objects and whether it's therapy or dental appliances to be in the mouth, that creates a lot of anxiety, and that's hard to cooperate with if we rely on that as our primary breathing space. So sometimes we do have to rely on something like surgery first in order to restore adequate airflow. But understanding that once that has been achieved, then we can turn to things like myofunctional therapy for better outcomes. We can turn to things like expanders that are now going to be better tolerated. And we know that we're really still taking a root cause approach here by supporting the body on its road to recovery. So typically, mouth breathing is not, quote unquote, just a habit. A lot of parents are told that their child will grow out of it, and that's something that I don't necessarily stand behind because there's significant research to suggest otherwise. So, for example, in one study, there were a group of children aged 3 to 9 years old, and they were evaluating who in that population was going to be identified as a mouth breather. And in that group, a little over half, 55%, were identified as mouth breathing children. And when they dove into the causes of what was underlying these issues, the most common causes here were allergic rhinitis, which is inflammation taking place inside of the nose, causing less breathing space inside of the nose to exist, enlarged adenoids, and enlarged tonsils. So sometimes we do have kind of structural issues going on inside of the nose that can make it harder to breathe. Something like the allergic rhinitis, that's kind of an inflammation response, but other times something structural like a deviated septal bone inside of the nose. Environmental contributing factors can be the driving factor behind some of that allergic rhinitis. So some of the more common environmental triggers for that can include dust mites, animal hairs, any sort of fungi or molds, and even pesticides can be some of the more common drivers here. We're focusing on this page on kind of some of the more likely things that are causing a structural obstruction or blockage for the easy breathing passageway, but it's not always just about structure. There are different things that relate to the function too, and there are some interesting nasal function tests out there, but we're not going to get into that for today's purposes. In a different study of 401 children that were referred to a clinic because they had noticed mouth breathing. So this is a different population than just like a general population. This was already a group that was identified as mouth breathing. And in that group, only around 9.5% were determined to be doing that because of a function. The rest of the group, around 90%, had an identifiable obstructive cause, again, going back to things like tonsils and adenoids or rhinitis. And sometimes it can be a habit, but it's certainly worth investigating and diving in further to see if there is an identifiable cause for this. These are some of the more common signs or signals that a child might have airway obstruction, and I've tried to divide them up a little bit by nighttime and daytime. But we have things like snoring, gasping or pauses in breathing, tooth grinding, restless sleep, or constant tossing and turning. You might notice the sheets are bunched up frequently, sleeping in unusual positions. That might include tilting the head back, or sometimes you see kids with kind of their booty up in the air. Night sweats, bedwetting, past an age where we would expect that. During the day, we might have mouth breathing or noisy breathing, picky eating, behavioral challenges or tantrums, difficulty focusing, frequent ear infections or respiratory illness, ongoing pacifier or thumb-sucking habits, and bad breath. So not every child is going to be a snorer. Some kids can be more quietly sleeping, but if they're still tossing and turning or having some of these other symptoms, it can still point us in the direction of an airway issue. So if your child is referred for, there's a suspicion of poor sleep or poor breathing, and you bring it up to your pediatrician, the most common situation is going to be a referral to an ear, nose, and throat doctor. And kind of the division of considerations at that point, if you go in, a lot of times is this kind of significant enough that it warrants tonsil and adenoid surgery or tonsillectomy and adenoidectomy? And that is going to be the removal, either completely or partially, of that tissue. And that's often considered a first-line treatment when either the tissues are significantly enlarged or if a sleep study shows a true diagnosis of obstructive sleep apnea. And it is true for sure that surgery does improve breathing in many children, but there are studies that have shown us that the complete normalization or resolution of breathing happens in only about 25% of cases following surgery. So some amount of breathing dysfunction can remain commonly. And if someone's considered not severe enough to require surgery, the other common considerations are going to be either sort of watchful waiting or medical management. So that could include something like nasal steroid sprays for short-term use, ongoing saline rinses for long-term use, allergy management of shots or medications, and for many families, this is often where the guidance stops. But one thing that I do love is there is a study of a set of children who were on a waiting list for 6 weeks because they were going to be referred to the ear, nose, and throat doctor based on large tonsils and adenoids. And during that time frame, they were set up using a saline spray for that period of time. And with no other changes instilled other than using this nasal spray, about 40% of the children who were on that waiting list no longer had symptoms that were concerning enough to require that referral to the ENT at the end of the 6 weeks. So I think that that's a pretty awesome study. And it's like, okay, if we do nothing else but try and do a nasal spray and see that we can get a good number of children better with simply that, that's always worth trying, in my opinion. And then again, surgery, I'm not saying surgery can't help, but it's often not going to be the entire solution when we look at kind of lifelong trajectory of getting proper breathing back. So what else exists? What else is there? If you're told to just kind of wait it out, know that it doesn't have to be like that. In the case that the ear, nose, and throat, the surgery happened, and we don't want to be that percentage of kids that didn't have the complete resolution, that's where kind of what else can we do, this falls into play here too. So I want to talk about how myofunctional therapy could fit in. And myofunctional therapy is going to be helping to retrain how the muscles of the tongue, the lips, and the face are functioning. These types of therapies have shown in the research to improve the metrics that are used in diagnosing and quantifying sleep disordered breathing. So things like obstructive sleep apnea or upper airway resistance syndrome. And they've also been used, this therapy has been used to promote better outcomes following tonsil and adenoid surgery. Now, please note that this research does not directly show a reduction of the tonsil and adenoid tissue size. What else is there? We have some research to show that expansion or widening of the jaws is a powerful tool when jaw development is narrow. And the research shows us that increased nasal space, reduced airway resistance, improved breathing, and again, a reduction in apnea severity was possible with expansion. In one study, 97.5% of children actually showed a reduction in the size of tonsils after expansion. And for those who argue, well, that just happens with age, we grow out of it, we get better. As the size of our airway grows, it's bigger. The counter argument here from that research study is that the control group actually showed increases in tissue size instead of decreases. What about these? These habit correcting appliances are oftentimes on the market, and it's something to consider if the tonsils are slightly enlarged or if we're having some, there's definitely good valid use to these when we're trying to encourage nasal breathing or support proper tongue posture. And there is some research to show us improvements in some sleep disordered breathing symptoms and oral habits. However, if a child cannot physically breathe through their nose, they are not going to tolerate these appliances and they will not be effective. So these appliances are not considered appropriate for children with significantly enlarged tonsils and adenoids, something like a grade 3 or 4. Again, I love these appliances for certain indications, but this isn't going to be your path to avoiding surgery if that's what you're looking for. Other considerations, anything we can do to reduce inflammation in the body is going to be helpful. That could be addressing food sensitivities, environmental allergies, chronic illness, and different ways that that can show up in the body. So maybe we're supporting better nutrition, microbiome health. I've definitely talked to families who have done approaches with functional medicine or homeopathy in order to get these tonsils to start shrinking. And while I definitely support that, even if we're at a size that's bigger, but we're not having a lot of symptoms, there's no apnea, then maybe we have more flexibility if things don't seem too bad to try some of these alternative paths. But if you have a child who's not sleeping well, who's struggling, I do see families who try for years to do everything more naturally and then end up still going into surgery. And I just think that it's an individualized decision. You have to kind of go into this in your own time, of course, but don't try to be a hero, I guess is what I'm saying. If we need help, we need help. So just to kind of recap where we stand with that, it's totally valid to want to try everything before surgery. I hear you, but if your child cannot breathe comfortably through their nose, again, all of these other routes can typically be harder. And even routines like brushing teeth or, again, picky eating, things like that can just cause a lot more stress. And if your child is struggling, one of the most supportive things we can do is remove that obstacle and then focus on rehabilitation in a more holistic way. Another question that comes up sometimes is, my child's going in, they're going to be sedated with anesthesia anyway for tonsil and adenoid. What do we want to do if the surgeon is saying, oh, we can just treat a tongue tie while they're sedated? This could sometimes feasibly be an option, but it's not an automatic yes. It's definitely a caution sign for me. When this might make sense is if there's a really significant restriction, a tie that goes all the way to the tip of the tongue, and it can just be that sort of anterior release that maybe can start the process of seeing progress, knowing that perhaps later a more involved approach is going to be part of the equation. Sometimes for these young kiddos around age 2 to 4, it's a lot harder to get compliance with exercises and activities. So maybe if your child's in that age group, it makes more sense, but there are providers in the country, some of the leaders that still will see patients of that age. It's not automatically ruled out that these patients need sedation. In fact, most tongue tie procedures do not require sedation. So it gives me pause. And then if, again, your child has a lot of feeding challenges present, perhaps it could be something to take advantage of. And for me, this is going to be a key decision if there's already a strong support team in place. If this is just being advertised as a quick fix, a simple snip, then red flags, yellow flags, all the flags are coming up for me. So before any sort of tongue tie release, we always want to be asking, has there been any preparation, any body therapy, any exercises? Is there a support team in place for aftercare and rehabilitation? Especially for the kiddos who are 4 and up, that's just really, for me, there's almost no excuse because once you're 4 years old, you qualify for most myofunctional therapy programs. And this sort of follow-up and preparation support, in my opinion, is that much more critical. And combining these procedures can sometimes be tricky. The rehabilitation, something like a lip tie, buccal tie is a lot easier compared to the rehabilitation required after something like a tongue tie. And if someone's already sore from having tonsil and adenoid surgery, it's going to make swallowing more difficult, and healing multiple areas at once can sometimes be too much if this kiddo's already sensitive or orally sensitive. So again, keeping in mind that most tongue tie releases don't require sedation in the first place. So oftentimes staging these things out is going to lead to a smoother recovery. My approach, as always, is there's no one size fits all here. No single treatment is going to solve everything. Surgery is great and a big stepping stone, a big needle mover, but it doesn't offer complete resolution. Therapy alone is fantastic, but in most cases, it's not going to be enough. Appliances are incredible, but they're not always going to be appropriate for every child. So the best outcomes here are going to come from combining the right tools at the right time for each unique child in the right moment. And the best way forward here is forward. My whole thing here is helping families that feel stuck or the decision to take here feels like it's too much. If you need help figuring out what that looks like for you, I am here to help. Thank you.